So case 1 is a 28-year-old male with midline neck swelling since 1 year, which was increasing rapidly since 2 months. There was mild difficulty in breathing on exertion. This, on examination, the patient had a diffuse 12 centimeter soft, non-tender cystic swelling. There were no neck nodes. Thyroid function tests were within normal limits. The CT scan showed a large mass which was epicentered in the right thyroid lobe. There was infiltration of strap muscles, partial infiltration of trachea, retrosternal extension, encasement of the right carotid artery. Clearly, the CT scan showed a malignant tumor. The FNAC from this thyroid tumor was very cellular, and the aspirates showed singly scattered cells, which were atypical, and there were no clusters, no papillae were identified. The cells at low magnification also appeared plasmacytoid in appearance. There was some multinucleation, which was identifiable. Again, the GIMSA smears also showed these cells, which were very cellular smears, which showed plasmacytoid cells, eccentrically placed nuclei, rounded nuclei, and oncocytic appearing cytoplasm. The higher magnification shows these plasmacytoid cells with rounded nuclei, eccentrically placed nuclei with intranuclear inclusions and new inclusion like macronucleoli. No grooves were identified. The cytoplasm was pale to oncocytic and did show very fine vacuolations. Some multinucleation was seen, and on pap smears, the nuclear atypia was much more prominent. Nuclear grooves similar to PAP-CA were not identified. There was binucleation, and what was brought out in these pap smears was the prominence of nucleoli. Some multinucleation can be appreciated here. Again, red prominent 1 to 2 multiple nucleoli were prominent. The cytoplasm was, in some cells, it appeared spindle to stellate. And the intranuclear inclusions were identified, but the cytologic atypia, the nuclear atypia, appeared quite conspicuous on these smears. Again, intranuclear inclusions were seen, but the cells started looking anaplastic. A few vascular fragments were also noted along with these cells. Occasional tumor cells showed intracytoplasmic vacuoles. Some of the cells were more spindle, but unequivocally, these tumor cells looked malignant. These, again, the pap smear shows multinucleation. Some tumor giant cells were noted. So this thyroid FNAC was called positive for malignancy, Bethesda category 6. Serum calcitonin was asked for to rule out medullary thyroid carcinoma, and at this point, anaplastic thyroid carcinoma was being considered as a differential diagnosis because this highly malignant-looking tumor was epicentered in the thyroid. Serum calcitonin was within normal limits. Serum CEA was normal. A thyroid biopsy was performed for the final diagnosis, and this biopsy course showed a very cellular tumor. The cells recapitulated the cytology features that we had seen on the FNAC. They were plasmacytoid with oncocytic cytoplasm. Again, plasmacytoid cells in diffuse sheets with eccentrically placed nuclei. Cells do show hyperchromatic, irregular nuclei, plasmacytoid morphology. And in some of the cores, a brownish pigment was identified, and we found intracytoplasmic blackish-brown fine pigment in the cytoplasm of the tumor cells. And with this, we did the melanoma markers, and tumor cells were positive for Melan S100 and HMB45, which are the markers for melanoma, and they were negative for epithelial markers. So the diagnosis was of a melanoma, and we did go back to the smears and found some scattered cells, tumor cells, which did show these blackish pigment again, but these cells were very far in scanty. So melanomas of thyroid are exceptionally rare tumors. Primary melanomas of thyroid are unreported. Mostly the involvement is as a part of metastatic disease, and that itself is extremely rare. In our case, this tumor presented as a primary thyroid malignancy. The large mass was found in the thyroid epicenter, in the thyroid 12 centimeters in size. No cutaneous or mucosal tumor was ever found in this patient. And the cytology, the pitfall, the important points about the cytology of melanoma in thyroid is that it can be mistaken for thyroid carcinoma, medullary carcinoma, the papillary carcinoma, and anaplastic carcinoma. And mainly that is mainly because the cytology features can overlap with these tumors. They can show epithelioid and spindle-shaped plasmacytoid appearance, intranuclear inclusions, macronucleoli, oncocytic cytoplasm, vacuoles may be present, and binucleation and multinucleation can be seen. Only half of the tumors would show pigment. Another caveat for melanoma is BRAF positivity, which we see in papillary thyroid carcinoma, can be seen in cutaneous melanomas. So that is one of the caveats. Our patient on PET scan did show, apart from this large unresectable thyroid tumor, metastatic disease in the lung and the liver, and he was given best supportive care. So uncommon tumors, rare tumors, which can mimic primary thyroid malignancies, can be seen. And so we move on to case 2, which is a 53-year-old female who presented with a thyroid swelling. This was a well-delineated 2.9 centimeter sized lesion on the thyroid. This nodule was effeminate. The smears were cellular, and they showed, again, singly scattered cells, there were hardly any clusters, and there were no papillae which were identified. There was a lot of crushing, which was also seen, but these appeared definitely neoplastic because of the cellularity. There was microfollicular arrangement. Very easily, readily, we could see microfollicular arrangement. But in addition to these microfollicles and the uniform cytology of the cells, what we found was these tumor cells had a lot of intracytoplasmic fine vacuoles, and these vacuoles were seen in the background as well. Many naked nuclei were also seen in the background. Again, here in this slide also, we see that the tumor cells had rounded nuclei, a visible nucleoli, and very fragile, delicate, pale cytoplasm without any cytoplasmic borders visible, and very conspicuous but fine vacuoles in the cytoplasm and also scattered in the background. Many naked nuclei with prominent nucleoli were also seen. So Pap smears were not great. They were hemorrhagic, but they recapitulated the findings of these neoplastic cells with low NC ratio and follicular arrangement. This was given as provisionally as a follicular neoplasm Bethesda category 4, but something was not fitting with the primary thyroid neoplasm. So we went back to the history of this patient and dug out the history, and we called the patient and asked the whole history, and found that 15 years ago, the patient had had a nephrectomy and was given a diagnosis of renal cell carcinoma. She had been well for 15 years and currently also did not have any local recurrence and had presented with a thyroid swelling. So the smears, when we, again, with this history, we reviewed them and we found that, yes, these are tumor cells with low NC ratio, with pale, wispy, delicate, fragile cytoplasm, and cells show a lot of abundant cytoplasmic vacuolations. And we gave a diagnosis of metastatic thyroid renal cell carcinoma. Metastatic renal cell carcinoma. The patient didn't have any local recurrence, but there were lesions in the pancreas and lung as well. All lesions were operable, and metastatectomy was performed for lesions at all three sites in the pancreas, lung, and thyroid. The thyroidectomy showed a very well delineated tumor and showed the classical histology of a low grade 1 clear cell renal cell carcinoma. Here we can see these tumor cells with plant cell appearance and clear cytoplasm. And these features can be seen in the cytology smears as well. These tumor cells have characteristically low NC ratio. The nuclear characteristic, they are centrally or eccentrically placed, and their characteristics vary according to the grade of the tumor. This was a low grade tumor, firm and grade 1. So these had smooth or slightly irregular nuclear contours, and nucleoli was just visible. And typically, the cytoplasm was vacuolated, wispy, and granular and delicately frothy. So this patient, after metastatectomy and complete excision of all the metastatic deposits, was put on sorafenib for 1 year. And after that, she has been on follow-up with no evidence of disease. So sometimes we can find odd tumors at odd sites, which we are not expecting, and they can mimic the original primary site tumors. So case 3 is a 38-year-old female who was a known case of hypothyroidism. She presented with a midline neck swelling, and this swelling was about 5 centimeters with retrosternal extension. Ultrasound showed multiple hypoechoic nodules involving both lobes, and the largest was 1.3 centimeter in the lower pole of right thyroid. PET scan, which the patient had already done from outside, showed a heterogeneously enhancing thyroid soft tissue, which was encasing the trachea and the larynx with erosion of the thyroid cartilage, and there were some mediastinal lymph nodes as well. Now the smears, the FNAC smears from this thyroid mass, they were cellular, and at low, again, these were singly scattered discohesive cells. No clusters, no papillae were identified. At this part, only the tumor, the atypical cells appeared very histiocytic in appearance, and there were some giant cells with peripherally placed nuclei that were seen, and these were admixed with lymphocytes. These atypical cells did have a histiocytic appearance. Some aggregations were also seen, but typical granulomas were not identified. And these cells did appear very histiocytic on morphology, and they were admixed with lymphocytes. When we looked at HIPAR, these cells appeared to show longitudinal grooves, some of them with very coffee bean appearance. And we started looking for eosinophils at this point because of these coffee bean longitudinal nuclear grooves, these nuclear convoluted nuclei, nuclear indentations, and general histiocytoid appearance of the cells. There weren't many eosinophils in the aspirates, but we did call it a malignant tumor, Bethesda category 6, and suggested the possibility of Langerhans cells histiocytosis based on these histiocytoid cells with nuclear atypia and longitudinal nuclear grooves. The biopsy was performed. Surprisingly, the biopsy had many eosinophils admixed with these tumor cells, and the tumor cells showed these histiocytoid appearance. Areas of necrosis were seen, and these tumor cells with pleomorphic nuclei and coffee bean longitudinal grooves were very characteristic of Langerhans cell histiocytosis, or LCH. This was confirmed with immunohistochemistry with CD1A and S100, and a diagnosis of Langerhans cell histiocytosis of thyroid was given. There was no evidence of any disease elsewhere, except there were no bony lesions. Now, thyroid involvement by LCH is extremely rare, with less than 75 cases reported. LCH cytology elsewhere, when we are mentally prepared for it in a child, in a bony lesion, it may be a relatively straightforward diagnosis, especially if we are aware of the cytological features. But a tumor presenting as a thyroid tumor or thyroid mass can throw off a young cytologist if this differential is not thought of. So this on cytology, we see cellular smears, disc cohesive cells with histiocytoid appearance, and longitudinal coffee bean nuclear grooves are the diagnostic hallmarks. And infiltrate of eosinophils is very helpful in making the diagnosis. The pitfalls because of the site can be that it can mimic chronic granulomatous thyroiditis, tuberculosis, and Hürthle cell-rich lymphocytic thyroiditis. And on the other hand, because of the nuclear grooves and the oncocytic appearance, it can mimic papillary thyroid carcinoma, Hürthle cell neoplasm, and also because the nuclear atypia and the nuclear convolutions can also rarely be mistaken for an anaplastic large cell lymphoma. So unusual tumors can involve thyroid, and that can overlap with the cytological features can overlap with primary neoplasms. Now, case 4 is a 24-year-old woman who had a slow-growing mass in the anterior neck for 1 year. And on examination, she had a well-defined paramedian region lesion or swelling, which was 2 to 3 centimeters, which moved with deglutition, was but otherwise freely mobile, firm in consistency. And ultrasound revealed a well-defined solid hypoechoic nodule, wider than taller, irregular halo, no microcal, no spongiform pattern. Extrathyroidal extension was not seen. The first FNAC which was done was ATP of uncertain significance, Bethesda category 3. A repeat FNAC was performed, and the smears, they again were cellular, and they showed many singly scattered cells. There were very few clusters, and here at this low magnification, microfollicular architecture was identified. Again, some vascular fragments can be appreciated. These the neoplastic cells have rounded nuclei and pale cytoplasm. And microfollicular architecture is quite conspicuous. There are some naked nuclei in the background. Here also we can see a vascular fragment here and the neoplastic cells. So clearly a neoplastic lesion. Then we find that if we have a closer look, we find that again there is hardly any nuclear pleomorphism. There weren't any nuclear grooves or inclusions, and the cytoplasm was pale and it started showing some granularity. Many naked nuclei in the background, vascular fragments, cells with vague microfollicular acinar arrangement and cytoplasmic granularity. PAP also did not show any nuclear features of papillary thyroid carcinoma. Some anisonucleosis was seen. And again, some clusters, but no definite papillae were identified. The cells on closer inspection showed very fine granularity, pale cytoplasm, and very fragile. No cytoplasmic borders were discernible, and there were many naked nuclei as well. Again, another view which shows very fine but conspicuous cytoplasmic granularity, and vascular cells admixed and enmeshed and associated with the blood vessels, vascular fragments, was also a conspicuous feature. So this was called as a follicular neoplasm, Bethesda category 4. The patient underwent hemithyroidectomy, and we received this tumor which was entirely confined within the thyroid. This was a well-circumscribed tumor, but did not have a complete capsule. And here we can see that there are some fibrous bands which are traversing this tumor, and their blood vessels can also be identified. And the tumor as such has this kind of solid nested appearance, and there are these fibrous bands which are traversing this tumor. Even at this power, we can see some dark hyperchromatic anisonucleosis can be seen, some multinucleation can be seen, and tumor cells appear oncocytic. But here we can see that on higher magnification, tumor cells show a very conspicuous nested appearance or a Zell-Ballen pattern, where these nests are separated by thin fibrovascular septi all around, and some random anisonucleosis is seen. Otherwise, the tumor cells are fairly monomorphic, and they show rounded nuclei with moderate to abundant eosinophilic cytoplasm. So hardly any mitosis is identified, and these nests can be appreciated better here. On immunohistochemistry, synaptophysin and chromogranin, they were positive. TTF1 and cytokeratin and calcitonin were negative. S100 highlighted the sustentacular cells around these nests. GATA3 was nuclear positive, and then based on this immunoprofile, a diagnosis of paraganglioma was suggested, and therefore SDHB immunohistochemistry was done. Here, there is no loss of SDHB. So this was a case of intrathyroidal paraganglioma, a very interesting and a rare case. So paraganglioma cytology, many of us would not be familiar with, because many of the this is mostly a radiology diagnosis, and paragangliomas are usually not needed for the fear of hypertensive crisis. But thankfully, this patient who was FNA twice did not suffer any complications, because this was a non-functional tumor. And cytology, we can be unfamiliar, but it can show remarkable if we do not know or are not aware of the site, or the tumor itself is intrathyroidal, then it can totally mimic follicular neoplasms or medullary thyroid carcinoma. On cytology, paragangliomas show clusters, microacini, rosettes. They are usually singly present, monomorphic plasmacytoid cells. They can have delicate, moderate amount of pale granular cytoplasm, as can be seen here, round to oval nuclei, anisonucleosis, and stipple nuclear chromatin. And because paraganglioma is a neuroendocrine tumor, it can mimic medullary thyroid carcinoma, follicular neoplasms, Hürthle cell neoplasms, and hyalonizing trabecular adenoma of thyroid. So interesting entity to be kept in mind. So coming to the last case, this is a case of 47-year-old male who noticed a swelling in the neck 2 to 3 months, which was gradually increasing. There was no difficulty in swallowing or breathing. There was no change in voice, but the swelling was large, 8 by 15 centimeters. It moved with deglutition, was mobile and non-tender. And the ultrasound revealed that the whole thyroid was replaced by this large hypoechoic mass, and there was extrathyroidal extension, and it was wider than taller, no halo, no few microcal, no spongiform pattern, and there was a metastatic right level 4 node as well. The FNAC from this was cellular, but most of the cells were degenerated. They showed singly scattered cells with a lot of cell size variation. And here we can see that most of the cells were degenerated, poorly preserved. Their cytoplasm was stripped. And many cells were large sized and were difficult to appreciate the cytological features. The pap smears again showed very pleomorphic nuclei, and they showed a lot of cell size variation, and background showed some lymphocytes. And these very large singly scattered atypical cells with prominent nucleoli were quite unsettling. There was a crushing artifact. Again, some malignant cells were seen entangled with these, and the tumor cells really showed marked cytologic and nuclear atypia, although the cell cytoplasm was not very well preserved. Nuclei mostly seen as naked nuclei without any preserved cytoplasm. So This was reported as malignant tumor, and because this was a large mass in the thyroid with an epicenter in the thyroid, the reporting pathologist gave a possibility of anaplastic thyroid carcinoma and also considered metastatic carcinoma. And a repeat FNAC was and a repeat biopsy was performed, and what we did show was a much better preserved cells now, and we find that these are singly scattered cells with high NC ratio admixed with lymphoid cells. There are still degenerated cells, but the cells which are preserved show high NC ratio, open chromatin with basophilic cytoplasm, and many lymphoglandular bodies could be seen in the background. Here we see it better that these are cells with open chromatin, basophilic scanty cytoplasm, cytoplasmic vascularity, and something that gives us a conclusive, a very solid clue is the lymphoglandular bodies, which are plenty in this background and tell us that this is again, a cell here we can see is much more evident that here we are dealing with a high-grade lymphoma here. So the biopsy also confirmed that there were infiltrating atypical lymphoid cells with a lot of crushing artifact, and immunohistochemistry confirmed that this was positive for LCA and B-cell marker and was called a diffuse large B-cell lymphoma. Now, thyroid lymphomas are rare malignancies. Usually it is because of in a background of Hashimoto's thyroiditis. Cytology shows monotonous population with large atypical lymphoid cells, scanty cytoplasm, fine granular chromatin, prominent nucleoli. But in this case, we saw that in the biopsy there was some fibrosis, and probably because of that, the aspirate showed a lot of pleomorphism, and the first aspirate was not very cellular, but mainly showed pleomorphic large-looking cells, which resembled anaplastic carcinoma. So lymphoglandular bodies are a big clue on GIMSA. Karyorexis and also favored for high-grade malignancy. So marked lymphomas are also occur in thyroid, and they may be mistaken for lymphocytic thyroiditis. So this patient received chemotherapy and is symptomatically better now. So we've seen assortment of rare diagnoses in thyroid FNAC, which caused a challenge while reporting. So it would be worthwhile to remember that while we see thyroid FNACs, which are very common, we see common thyroid FNAC is a common material for reporting in cytology. Uncommonly, thyroid can be involved by melanoma, by metastatic carcinoma or metastatic tumors, paraganglioma, Langerhans cell histiocytosis, lymphoma, and it can be, because of the site, it can be mistaken for commoner pathologic entities and malignancies. And also many of the malignancies can mimic primary thyroid neoplasms. So to hit the correct diagnosis, we need to be alert, and sometimes we have to think outside the box and also think of entities which we may not commonly see there. And then a cup of coffee definitely helps. Thank you for your attention.